All right, so we're going to get started tonight. So very good evening. So this is the most amazing part of the year. And I just returned back from India. This is considered the most auspicious part of the Indian culture time. There are two big events that happen. One is called as Dashera, and the other one is the Diwali. So this is the week in between the two, and anything good that you want to do. Typically, people want to do during this time, start new projects, buy new things. So this is a very important in the Indian culture. The reason I'm mentioning that today is because it's going to be the beginning of a new culture also in Robert Wood Johnson Medical School and the University Hospital, with the formalization of the Women's Heart Clinic. We have been speaking about this for a very long time. And with that, the potentials of bringing the cardio-obstetrics program is really very heartening. And this will be a great service for the cardiovascular service line and for everyone here, so that people with high-risk pregnancies would not have to leave the state and go elsewhere. Before we get into the details of the grand rounds today, I'm just going to go over some of the nominal things that we typically introduce for any grand rounds, and that would be to have the CME credits available. For that today, you can text at 20382 to the number 888-816-4893, and this will take you to the CME credit sessions. You need to have your active profile in Rutgers Cloud CME. And if you're a physician and you would like to get your MOC points, and fortunately, we have had a tremendous uptake of MOC points recently. So thank you for that, because it makes us have this opportunity provided to all of you. So please use this link that will be again redisplayed in the chat box. And then you will have the room code future56, and you will have to answer the few questions. And if you do that correctly, you will have your ABIM ID credited with the MOC points. With that, I'm really very happy tonight to be able to introduce Dr. Yanting Wang. Dr. Wang is Assistant Professor of Cardiology. She just joined this month with us. She was referred for this position by a very close friend and colleague, Lisa Sugang, who trained her, and she was really having profound praise for her work ethics, her diligence in clinical cardiology, and her passion for women heart clinics. So we are really happy that she took the position. She did her medical degree from University of Pittsburgh School, and then she had also residency in internal medicine and women's health at University of Pittsburgh Medical Center and Maggie Women's Hospital. She pursued a cardiology fellowship at Yale New Haven University, and she had specialized training in cardio-obstetrics and women's cardiology there. Her specific interests include management of peri and postpartum hypertensive disorders, pregnancy with structural heart diseases, microvascular dysfunction as a common cause of chest pain in women, and really under-recognized condition, and also to take care of post-menopausal women, specifically if they would have significant cardiovascular diseases like autoimmune cardiovascular diseases. Now, she has a tremendous record as an educator. She was nominated for the Yale's Fellows, by the Yale's Fellows as a medical educator program. It's called as the FAME program. And she piloted a women's cardiovascular health curriculum for medical students sponsored by the Yale's Women Health Research Center. She also participated in the Connecticut American Heart Association and was invited as panelist in the AHA Go Red and the CTHA STEM Go Red events there. Prior to joining Rutgers, Dr. Wang had a brief stay with Hackensack Jersey Shore Medical Center, and we are so pleased that she decided to come and join us. Also, we are extremely delighted today to bring in as our panelist, Dr. Ruchira Sharma. Dr. Sharma is the Assistant Professor, Division of Maternal Fetal Medicine, Department of OBGYN and Reproductive Sciences. And together with Yanting Wang today, I think we're going to have some good time to discuss the potential opportunities that are here that we can really work towards. So thank you both of you for joining us. And without any further delays, Dr. Wang, the time is here for you to be able to present your grand rounds. You're muted.
Okay, I will share my screen. Thank you. Can you hear me?
Yes, perfect.
Okay. Thank you for inviting me to have an opportunity to talk about something I'm extremely passionate about, which is the emerging field of cardio-obstetrics. And I want to talk about some considerations that we should take as cardiologists in taking care of women during their pregnancy. So for this talk, I will focus on the impact and prevalence of cardiovascular disease on maternal health, disparities within our maternal care, cardiovascular risk factors in pregnancy, and I will review the hemodynamic changes during pregnancy and how to risk stratify and evaluate women during, before, and after pregnancy, and some avenues for improvement within our community and our healthcare system. I'd like to start off the talk with a case presentation. We have a 36-year-old first-time mother with a history of pulmonary embolism, first day after her C-section. She reports to her bedside nurse of sudden onset shortness of breath and requests for a CT scan of her lungs. The nurse thought, however, that perhaps the pain medication might be making the patient confused and did not reach out to the physician right away. The patient insisted on speaking with the doctor so that a CT scan could be ordered. Ultimately, the physician orders an ultrasound of her legs, which was negative for a DVT, and the patient's dyspnea and cough worsened. Eventually, the CT scan was ordered and showed several small pulmonary embolism. Unfortunately, due to worsening cough, the patient's C-section wound reopened and she had significant hemorrhage while on an IV heparin drip and was taken emergently to the operation room for surgical revision. And this is the true story of Serena Williams, published in the New York Times and Vogue magazine. It highlights that even this tennis superhero, winner of 23 Grand Slams, was not immune to the complications, challenges, and biases that new mothers face after childbirth. Now, where does the United States stand on maternal mortality? From a global perspective, more women in the United States die from pregnancy-related complication than any other developed country. And this is a nation that has been to the moon, has developed self-driving cars, and yet dying from childbirth is not a myth, but a sobering reality. Maternal mortality is a public metric which should be just as important as the country's GDP. And as such, there needs to be significant improvements to our approach to maternal care. This is a report from the CDC Maternal Mortality Review for the years of 2018 and 2021. The New Jersey maternal mortality is about 26 per 100,000 live births, and this lands in the median with respect to national statistics. However, New Jersey is higher compared to our northeastern peers, New York, Connecticut, Pennsylvania, Maryland, and Massachusetts. I think it's really important to first revisit some important milestones in women's health and mention several important time points. In the 1970s, the Maternal and Child Health Epidemiology Program was established by the CDC to study maternal and birth outcomes. 2 decades later, in 1990, the NIH opens the Office of Research on Women's Health, and Dr. Bernadine Healy became the first female director of the NIH, and she launches the Women's Health Initiative. Between 1997 and 2001, various pregnancy risk models were developed to include the CARB-REG, Zahara, and the WHO risk model. And more recently, in 2018, the United States government passed the Preventing Maternal Death Act to eliminate disparities in maternal health outcomes and identify solutions to improve care. This graph was published by the CDC Pregnancy Mortality Surveillance System, showing the deaths between 1987 up until 2018. As you can see, the pregnancy-related mortality in the United States continues to climb and has steadily increased from 7.2 deaths per 100 live births in 1987 to 17.3 deaths per 100,000 live births in 2018. And this is the same year that the United States passed the Preventing Maternal Death Act. However, despite our national efforts to reduce maternal mortality, there continues to be a rise in maternal deaths, and this is primarily in our non-Hispanic Black population. Now, when do women experience complications? A little under half of the mortality occurs during pregnancy or the day of delivery, but the majority is missed and occur during the first 45 days postpartum up to a year. It is this fourth trimester after the actual childbirth that is the key to prevention and intervention. And what are the causes for maternal death? I also like this graphic because it shows how the causes of maternal mortality has changed over the last 3 decades. In the early 90s, the major causes of maternal mortality were hemorrhage, hypertensive diseases, infection, and thromboembolism. However, as you can see, these causes have significantly decreased, and now we see an increase in cardiovascular causes. Cardiovascular conditions combined account for nearly 40% of all pregnancy-related deaths, with 12.1% from cardiomyopathy, 6.9% from hypertensive disorders, 5.8% from cerebral vascular events, and the remaining 14.5% from other causes that include valvular heart disease, coronary events, aortic disease, and congenital heart conditions. Not only does cardiovascular disease account for a significant portion of maternal mortality, but the prevalence is rising among our pregnant patient population. One of the reasons is the age at which women become pregnant is increasing. Women are now delaying pregnancy to focus on their careers and achieving financial stability. Additionally, there has been significant improvements in our reproductive endocrine technologies, such as IVF and IUI. And lastly, as our medical technologies improve, survival among our congenital patients are improving, and they are growing into the reproductive age. With our growing and aging reproductive population accompanies an increase in cardiovascular risk factors. Additionally, we have also done a poor job in this country of tackling the obesity epidemic, and along with it, its comorbidities, hypertension, hyperlipidemia, and insulin resistance. In fact, many cardiovascular deaths are preventable, and cardiovascular mortality and morbidity is modifiable. A report from the 9-state Maternal Mortality Review Committee, which was published in 2018, estimated that 63% of all pregnancy-related deaths were preventable. Among the cardiovascular and coronary-related deaths, 68% were preventable. The committee further evaluated contributing factors that led to the deaths in pregnancy. The majority of the factors were patient-related, which includes risk factors such as obesity and hypertension, followed by provider and systems factors. Provider-related factors include knowledge deficits, delayed diagnosis, and delayed referral of patients. System-related factors include the lack of communications between the providers caring for a pregnant patient and lack of access of care for a patient. We've now looked at the significance and impact of maternal deaths and the fact that we desperately need to alter the trajectory moving forward. Before I talk about cardiac disease during pregnancy, I'd like to briefly talk about the hemodynamic changes that occur. We often say in cardio-obstetrics that pregnancy is a woman's first stress test and a window into her future. And the way I explain to my patients, and for anyone who's gone through pregnancy and may very well be aware, that being pregnant feels like you are running on a treadmill for the entire 9 months that you are pregnant, and your heart is working overtime. The body goes through significant hemodynamic changes to meet the maternal and fetal metabolic demand, and this includes an increase in the cardiac output. When we think about the equation for cardiac output, we think about two things: heart rate and stroke volume. During pregnancy, the heart rate slowly increases in the first 12 weeks of pregnancy and then plateaus. Then there's a second increase in heart rate in the late third trimester, which peaks during active contraction. With this increase in heart rate often comes an expected increase in PACs and PVCs. However, an abrupt onset or an abrupt offset of tachyarrhythmias is never normal, and I advise women to seek further evaluation because arrhythmias are also more common in pregnancy, especially during the time when the average heart rate is increased in the third trimester. Now, plasma volume also increases throughout pregnancy and is accompanied by a slight increase in the ventricular and atrial chamber sizes to accommodate this increase in volume. And although many women may not be visibly pregnant at 12 weeks, by then their cardiac output has now doubled compared to the pre-pregnancy state. During pregnancy, it's also really important to remember that cardiac output is also affected by the position. Cardiac output is the highest during the left decubitus position and the lowest in the supine and right decubitus position, as the IVC is compressed by the gravid uterus. And overall, despite this increase in the cardiac output and stroke volume, the ejection fraction is often unchanged. The next important change that occurs in pregnancy is the red blood cell mass. The red blood cell mass also increases to accommodate for an increase in the oxygen demand to supply the placenta and the fetus. The red blood cell mass increases steadily in the first 2 semesters, peaking in the third trimester. However, this increase is less than that of the plasma volume, and it results in a reduced hematocrit and a reduced blood viscosity. This is an important change as the reduction in blood viscosity reduces the effort needed to perfuse the small arteries within the placenta and functionally reduces the afterload. An absence of this physiologic anemia, such as in those with cyanotic heart disease, may actually be harmful and increases the patient to an elevated risk for still and preterm birth. Next, there's a rapid reduction in the systemic vascular resistance during the second trimester, which further helps reduce the resistance and improve perfusion to the placenta and the uterus. However, unlike the vascular resistance, blood pressure does not dramatically change from pre-pregnancy to pregnancy state due to the compensatory increase in plasma volume, balancing the reduction in vascular resistance. Now, what happens during active labor? In the second stage of labor, when the cervix is fully dilated and women are actively pushing, their heart rate increases and their arterial blood pressure increase. The stroke volume also is augmented by autotransfusion between contractions, and therefore pain management during labor and delivery becomes critically important in patients sensitive to hemodynamic shifts. Reducing pain will help optimize these shifts in patients with underlying cardiovascular disease, and therefore a pain plan should be clearly communicated and planned in advance and discussed with all members involved in the labor and delivery process. Now, what happens postpartum? As much as half a liter of blood previously sequestered in the maternal circulation is now in the ureteroplacental circulation is now auto-transfused back into the maternal circulation. However, this changes in cardiac output and vascular resistance do not return back to normal for another 3 to 6 months. And for this reason, many women may continue to have pregnancy and cardiovascular related symptoms long after delivery. Understanding these normal physiologic changes in pregnancy will help us understand and treat abnormal physiology in women with underlying heart disease. And in general, regurgitant lesions tend to be better tolerated than stenotic lesions due to the physiologic afterload reduction that occurs during pregnancy. We've discussed the normal hemodynamics during pregnancy. we can now talk about how to take care of a woman during their pregnancy. Really, a care of a pregnant patient actually starts before pregnancy. Preconception counseling can be just as important as the pregnancy management itself. Regardless of what specialty we are in, I think it's important to ask any women of childbearing age whether or not they are considering a possibility of pregnancy in the future. Counseling a patient on the risk of pregnancy should ideally, again, take place before conception to allow an informed decision about the true risk of pregnancy and time to optimize the maternal status, including a thorough review of any potentially teratogenic medication and the use of alternative and safer meds. Women who are at risk for adverse events should be referred for preconception counseling, and these women include those with chronic hypertension, who are at 13 times increase in having a myocardial infarction, an 8-time increase in having heart failure. Women with dyslipidemia or an elevated BMI above 30 or even 25, women with diabetes or glucose intolerance, polycystic ovarian syndrome, any smoking history or any autoimmune disease, and advanced maternal age above 40, which is also associated with a 30-time increase in heart disease-related deaths compared to their 20-year-old counterparts. Now, there are several risk stratification models that we can use to help guide our patients. And although no tool is perfect, they are a good starting point for preconception counseling, determining the frequency of monitoring during pregnancy and guiding the level of care needed for delivery in the postpartum period. The original CARPREC model, which was published in 2001, includes 4 variables: the prior cardiac arrest, their NYHA functional classification, any impaired systemic ventricular function, or left-sided obstruction. More recently, the CARPREC 2 was released in 2018 with additional variables that include pulmonary hypertension, coronary artery disease, aortopathies, prior cardiac intervention, and a late pregnancy assessment. The Sahara model is used exclusively in women with congenital heart conditions, and that includes 8 different variables: a history of arrhythmia, cardiac medications prior to pregnancy, their NYHA functional status, any moderate or severe mitral or tricuspid valve regurgitation, left heart obstruction, history of mechanical valve, and cyanotic heart disease. The WHO risk model includes specific conditions and are categorized for 1 through 4. Patients in category 4 are typically recommended against pregnancy as their risk is prohibitively high. Category 4 conditions include pulmonary arterial hypertension of any cause, left heart dysfunction defined as EF less than 30%, or a NYHA class of 3 to 4, any Marfan's patients with an aorta bigger than 4.5 centimeters, or bicuspid patients greater than 5.0 centimeters, any stenotic valve lesion with aortic valve size less than 1 centimeters, or mitral valve size less than 1.5. And it is imperative that we identify these patients early to either modify their risk factors or advise them against pregnancy. And when comparing these 4 risk models, we have found that the CARPREC 2 has the highest discriminatory power, followed by the WHO risk model. Patients with at least 1 CARPREC risk factor had a risk of 5% chance of developing adverse events during their pregnancy. And in practice, we can use CARPREC 2 to help counsel our patients about their risk of pregnancy, and the WHO to guide surveillance and follow-up. Next, when our patients become pregnant, we need to continue to modify their risk factors and treat any conditions that may arise. And this includes a very multidisciplinary team of cardio-obstetrics specialists, including maternal fetal medicine, the cardiologist, anesthesiologist, and the nursing system. This team must include an active and fluid communication so that we provide the best care for our patient. Once we have risk stratified our patients, we can help use the risk models to triage their care. Low-risk patients, or those with WHO-1 classification, can receive care at their local hospital with coordination between their primary cardiologist and their primary obstetrician. And they can be followed up about once or twice as needed or as symptoms arise. Patients who are at moderate risk for adverse events, or WHO-2 classification, should deliver at a hospital with a cardio-obstetrics team or refer to a hospital with a cardio-obstetrics team that includes maternal fetal medicine and a cardiologist specializing in obstetric care. And these patients can be seen about once per trimester. Now, women who are determined to have high risk and prohibitive risk for cardiovascular events during pregnancy should really be managed at an expert center with a variety and access to experts. And this team should include not only the maternal fetal medicine specialist, the cardiac specialist with specialized care in pregnant patients, but also ad hoc members such as interventional cardiologists, cardiac surgeons, and advanced heart failure. Patients with group 3 classification can be seen bi-monthly, and those with group 4 should be really followed on a monthly basis. Now, how do we address symptoms that arise during pregnancy? Well, I really treat any new symptom during pregnancy as a cardiac symptom until ruled out otherwise. Normal pregnancy symptoms can often overlap with symptoms of underlying heart disease. And sometimes symptoms are just from normal physiologic changes, like I mentioned before. However, these tend to be mild and self-limiting, often not associated with any physical findings. As patients start developing physical findings and moderate to severe symptoms, they need a very thorough and extensive evaluation. Red flag symptoms include shortness of breath, orthopnea, tachycardia, heart rate above 120, a resting blood pressure above 160 or even 140, as I will talk about later, and hypoxia should prompt emergent evaluation. This is a very nice algorithm I want to highlight from the California Maternal Quality Toolkit. I highlight this because California is one of the only 3 states in the country which has successfully reduced their state maternal mortality by piloting the statewide toolkit. This toolkit was validated internally by applying to a retrospective cohort of maternal deaths, and it demonstrated that 88% of cases would have been identified earlier had the screening tool been applied. If patients have any high-risk symptoms or risk factors, then they warranted further testing with at minimum an EKG, BNP, and echocardiogram. If those 3 are within normal, then patients can be followed up routinely. However, any of these are abnormal, then they should be referred to a cardio-obstetrics team. And this graph again highlights the success that California has had in lowering their maternal mortality in the state. The California Maternal Quality Collaborative was founded in 2006 and then piloted this toolkit in 2008. And now California has the lowest maternal mortality of all 50 states. I would like to also highlight and talk about cardiac biomarkers in pregnancy. For BNP, both BNP and NT-proBNP retain their negative predictive value to exclude heart failure in pregnancy and the peripartum period. BNP levels in pregnancy should really remain normal despite the increase in volume, and therefore an elevated BNP in pregnancy should warrant further evaluation. An abnormal BNP level above 100 is diagnostic for heart failure with a sensitivity and specificity of 90% and 76% respectively. In patients with signs or symptoms of preeclampsia or heart failure, we do recommend that we obtain a BNP at the time of presentation. And for patients with other pre-existing heart conditions, you can consider obtaining a baseline BNP and following BNP serially, as the level of BNP is predictive of future adverse events during that pregnancy. To avoid diagnosis, we suggest that we lower the threshold for BNP to 50 for all trimesters. And if you're using NT-proBNP, that level should be 200 for the first and second trimester and 150 for the third trimester. In terms of troponins, the conventional troponin T and conventional troponin I both have high specificity, while our newer generation high sensitivity troponins, as the name would suggest, have high sensitivity at the expense of lower specificity. Studies have shown that conventional troponin T remains negative throughout pregnancy, but may increase with certain cardiac diseases. Troponins, however, should not be ordered routinely without any clinical context. However, if we are concerned for active ischemia or pulmonary embolism, then we should order a troponin in an expedited manner. In peripartum cardiomyopathy specifically, a troponin can add a prognostic value as well. Incident troponin values are inversely related with the likelihood of LV recovery in peripartum cardiomyopathy. And the use of high-sensitivity troponin is preferred to avoid delayed diagnosis. And as a general rule, any elevated troponins should be further evaluated during pregnancy. Now, I want to talk about another elephant in the room, which is the medication safety in pregnancy, an area where there's major deficit in research and knowledge. Since the 1960s, when the teratogenic effects of thalidomide in pregnancy was revealed, there has been a heightened public concern about the use of medication in pregnancy. The FDA responded to this event by requiring animal studies to help assess the safety of medications. And at that time, they introduced a 5-tier alphabet system to categorize medication, A, B, C, D, and X. Category A medications are considered safe, and category X are considered contraindicated, which is pretty cut and clear. The gray area lies within the surrounding categories B, C, and D, as there was much ambiguity in the safety data and also misinterpretation. For example, a drug with an adverse data in animals could be labeled as the same category as a drug with no animal data. Therefore, in 2015, the FDA adopted a new system, PLL, also known as Pregnancy and Lactation Labeling Rule. Instead of using an arbitrary lettering system, there will now be a detailed risk summary and associated risk of untreated disease to allow physicians and patients to make a more individualized risk-benefit analysis and decision regarding starting a medication. This also reduces the innocent until proven guilty phenomenon, where a newer untested drug with no known harmful effects in pregnancy was perceived as safe and previously categorized as B, compared to a drug with known adverse events and adverse outcomes in pregnancy categorized as C. I highlight this table here, which summarizes some of the more common cardiovascular drugs used. Beta blockers are considered pretty safe, except for atenolol, which is known to be associated with intrauterine growth restrictions. It is also worth mentioning that if a woman is on a beta blocker throughout her pregnancy, we might want to mention to the pediatrician or neonatologist that there is a risk of hypoglycemia after a birth. Calcium channel blockers are also considered pretty safe, but specifically some preferred over the others. Nifedipine has the best safety data and is used first line in hypertension, and diltiazem is the least preferred. Diuretics are also considered safe, such as furosemide, and can be used in pregnancy, especially if the patient's presenting with symptoms of volume overload. We do try to avoid overdiuresis, as there is a risk of placental hypoperfusion. And lastly, just a word about statins, which were previously contraindicated in pregnancy, which was based on very early observational animal data. The FDA has now relabeled the statin indications. The FDA has now removed contraindications from statins, with the caveat that women should still avoid statins if they have no strong indication. In women with very high risk, such as women with homozygous familial hypercholesterolemia, or women who are using statins as secondary prevention, such as those with prior stroke, myocardial infarction, or has a percutaneous stent, these women can continue their statin. Hydrophilic statins, such as rosuvastatin and pravastatin, are preferred over the others. Next, I want to talk about timing and delivery modality. For timing, patients with stable cardiovascular disease can deliver at 39 weeks or later, and earlier delivery can be considered for those at higher risk, but this needs to be discussed with our multidisciplinary team, including our maternal fetal medicine colleagues, neonatologists, as well as pediatricians. The mode of delivery, so vaginal birth is almost always preferred over C-section, as it's associated with better outcomes, with a few exceptions. C-section is recommended for patients with an aortopathy with an aorta bigger than 4.0 in Marfan's and 4.5 in bicuspid patients. Patients who are on therapeutic Coumadin or vitamin K antagonists are at an increased risk of fetal intracranial hemorrhage for vaginal births, so therefore C-section is also generally recommended. Relative indications for C-section, which is more debatable, include patients with more severe pulmonary hypertension, aortic and mitral stenosis. For monitoring, low risk and stable patients can be delivered without any telemetry or advanced hemodynamic monitors, and patients with significant arrhythmia histories, such as SVT or VT, typically deliver with telemetry. Patients with congenital valvular pulmonary hypertension may require more invasive hemodynamic monitor, such as a right heart cath or swan place, along with central line if more central access needed. And the delivery location may be in the intensive care unit or the operation room to allow easy access to convert into a C-section as if needed. And what happens after birth? Well, the role of the cardiologist does not just end here. Patients who have experienced an adverse pregnancy outcome or have risk factors for an adverse outcome in the future need to be followed up upon closely after delivery. As I had mentioned before, the fourth trimester is a period following delivery through the first 12 weeks postpartum, and it is this vital period that is critical, as over 70% of deaths occur, and nearly 40% occur in the first 6 weeks and up to a year. However, approximately 40% of patients do not actually attend to their postpartum visit, whether it be due to stress of becoming a new mother, socioeconomic barriers, or lack of transportation. Care during this fourth trimester needs to be focused on screening and for early intervention of high-risk individuals, such as those with chronic kidney disease, diabetes, gestational complications, including preterm birth, intrauterine growth restriction, and those with advanced maternal age. Cardiovascular screening should occur within the first 3 months after they deliver and include a detailed history, monitoring the postpartum medications, and a screening laboratory, including a basic metabolic panel, lipids, and urine protein. One of the most critically important and underutilized interventions in the care of a prepartum and postpartum woman is contraception counseling. Both the ACC and the AHA recommend that women receive contraception counseling if they have underlying heart disease for one of two reasons. One, it allows us time to optimize their maternal status and any medications that they need to for treating their symptoms and their conditions. And two, it allows us to prevent pregnancy if their risk is prohibitive. Another reason for preconception counseling, it allows us time to plan for any imaging needed prior to their pregnancy, and that includes the use of iodine contrast or gadolinium contrast, as well as echo enhancers. Both the cardiologist needs to have a basic understanding of contraception counseling and able to provide adequate and accurate counseling of contraception. So I try to simplify birth control for cardiologists by thinking of it in two different categories: the effective and the non-effective. Highly effective birth controls include the long-acting reversible contraceptions, also known as the LARCs, and these include the intrauterine devices and the implantable progesterone rods. Their real-life failure rate is less than 1%. Less efficacious methods include the progesterone injections, the Depo-Vera, which is given every 3 months, the combined oral contraception pills, transdermal patches or rings, and these have a failure rate of up to 8%. The progesterone-only pill, also known as the mini pill, has a very high failure rate of up to 10%. Now, I try to think of counseling in 3 basic steps for my cardiovascular patients. The first step is asking ourselves, well, what is really at stake here? For patients who are at very high risk or prohibitive risk for adverse events, WHO class 3 to 4, and these again include patients with pulmonary hypertension, LVEF less than 30%, aortic or mitral stenosis, any aortopathies, or patients who are already known to be on teratogenic medications such as Coumadin or amiodarone, should be offered the most effective contraception. And these include the subdermal implant and intrauterine device. Step 2 is asking ourselves, who can't be on estrogen? Well, estrogen-containing birth control increases the risk of thrombosis and hypertension in our patients. Patients who are already at high risk for thrombosis, we should avoid estrogen. And these include patients with known atrial fibrillation, mechanical valves, right to left shunts, coronary or aortic disease, prior thromboembolisms, or severe left ventricular dysfunction. Patients who are already hypertensive, we tend to avoid any estrogen-containing medications as well. Progesterone-only birth control can include double injections and the mini pill, as I mentioned. And these are in addition to your long-acting, very effective contraception methods. Now, for my low-risk patients who have the full spectrum of options, we can consider secondary benefits of the various contraception methods. Hormonal IUDs and progesterone shots are associated with decreased menstrual bleeding, while copper IUDs and implantable progesterone rods are associated with increased menstrual bleeding. And we can typically avoid those in patients with known anemia. Weight gain is associated with the progesterone shots, and for patients who have already obesity or metabolic syndromes, we should typically avoid those. Now, the second underutilized intervention is breastfeeding counseling. The United States also has the lowest breastfeeding and breast milk feeding rates in the world. Women are often counseled on the benefits of breastfeeding for the infant, but there also needs to be an increased awareness of the benefits for breastfeeding for the mother. Breastfeeding is associated with a reduced risk of stroke, heart disease, and diabetes. And there are only very rare instances where breastfeeding is truly contraindicated from a cardiovascular perspective. And women who have experienced an adverse event in pregnancy should be treated similarly as a woman who had an abnormal stress test. And these patients should be followed long-term for secondary prevention. Experiencing an adverse event during pregnancy, whether it be preterm delivery, small or large for gestational age, placental abruption, all accentuates the cardiovascular risk trajectory for the woman long-term and should be treated similarly to our other traditional risk factors such as diabetes. Preeclampsia increases our risk of developing hypertension, stroke, diabetes, and ischemic heart disease by nearly twofold. It increases the risk of heart failure by nearly fourfold. Having gestational diabetes increases the risk of developing chronic diabetes by nearly sevenfold and increases the risk of ischemic heart disease by twofold. Preterm birth itself is also associated with a significant increase in the future stroke risk. And however, despite knowing this, many young women are often lost to a follow-up after graduating from our OBGYN colleagues and don't reconnect to their care until they've landed in your clinic for now a second or third adverse events such as heart failure or myocardial infarction. And as such, the American Heart Association Guideline for Prevention of Heart Disease recommends that pregnancy history be incorporated into the full assessment of a woman, and we as cardiologists should routinely ask our women about their pregnancy history and any adverse events they've experienced. Women who are identified with these sex-specific risk factors should undergo early and frequent screening for hypertension, diabetes, lipid disorder, and any other metabolic syndrome. Next, aggressive lifestyle modification should be recommended, and things such as the AHA Life Simple 7 can be encouraged to help with weight loss, healthy diet, and exercise. And lastly, early statin initiation or intensification of their current regimen should be considered for patients aged 40 to 75 who are at intermediate or borderline risk with the presence of these non-traditional risk factors. And I have a low threshold of attaining a coronary calcium score in these patients to further help risk stratify them. As the last part of this talk, I would like to mention some recent updates in the guidelines regarding caring for women with one of the most common diseases affecting our maternal population, hypertension. Chronic hypertension is defined as any blood pressure above 140/90 that occurs before 20 weeks of gestation. Gestational hypertension is defined as blood pressure of 140/90 after 20 weeks of gestation. Preeclampsia and eclampsia are both severe forms and are defined as hypertension with end organ damage or proteinuria. Now, of course, we can have a superimposed state of preeclampsia on top of our chronic hypertension. For all hypertensive diseases of pregnancy, hypertension is unified by the definition of blood pressure above 140/90. However, the treatment threshold vary between the different continents and different societies. This adds to the confusion and contributes to the poor management of our patients during their pregnancy. The American College of Obstetrics and Gynecology had previously recommended antihypertensives be started on patients when their blood pressure is above 160/110 diastolic. Internationally, however, countries in Europe and Canada adopted a more aggressive approach, recommending treatments be started as low as 140/90. Now, why in the US was our threshold much higher compared to our counterparts? This is a complicated recommendation, as there previously had been only very small sized trials with very short duration between 4 to 9 months. This was compounded by the concern that lowering the placental perfusion would have an adverse fetal outcome. And third, there was concern about the exposure of the fetus to this long period of antihypertensive medication. Unfortunately, in 2022, at the ACC, there was a late-breaking trial called the CHAP. And this was simultaneously published in the New England Journal of Medicine, and it looked at chronic hypertension in pregnancy. This was an open-label randomized controlled trial enrolling over 2,400 women with mild hypertension defined as a blood pressure less than 160/110 who were less than 20 weeks pregnant between the years of 2015 and 2021. Patients were then randomized to receive aggressive blood pressure control less than 140/90 versus a traditional lenient threshold of 160/105. Patients in the treatment group received either labetalol or nifedipine, primarily as first-line antihypertensives, although amlodipine and methyldopa could be used if needed. Medications were then titrated to maximum dose prior to escalating to a second agent. For women who are already taking other blood pressure medications, they could remain on that drug as long as it was determined to be safe during pregnancy. This trial was extremely diverse, and nearly 50% of the population were non-Black or Hispanic. Patients in both the interventional and control arm had similar baseline characteristics. And the primary outcome, which is a composite of preeclampsia, preterm birth less than 35 weeks, placental abruption, neonatal or fetal deaths, were lower in their interventional arm at 30% compared to the control arm at 37%. The number needed to treat was only about 15 patients. Looking at what drove this outcome were preeclampsia with severe features, as well as preterm birth before 35 weeks. And looking at the safety, their primary outcome was the small for gestational age, and there were small for gestational age and birth weight. And there were no significant differences between the two arms, the intensive blood pressure threshold and the lenient blood pressure threshold. As such, both the American College of Obstetrics and Gynecology, as well as the Society for Maternal Fetal Medicine, published a statement shortly after recommending the use of tighter blood pressure control in women with chronic hypertension and earlier treatments, starting now at 140/90, with the understanding that what the CHAP study did not establish was the target blood pressure. How low should we go, and how low can we go before there are adverse fetal outcomes? And as such, there remains so much to be learned about blood pressure management during pregnancy. As a conclusion, it really does take a village to take care of a woman before, during, and after the pregnancy at both the provider level and the systems level. The cardio-obstetrics team should include a wide spectrum of members, ranging from social work, nursing, pharmacy, physicians, and administrators. From a systems level, physicians and their healthcare systems need to work with our policymakers to truly affect change and improve the care of our pregnant patients and new mothers. Thank you.
Thank you, Dr. Wang. Could you please stop sharing the screen? Okay. Unfortunately, Dr. Sengupta had an emergency and the patient emergency, so he had to leave. I would like Dr. Sharma, if you can go ahead and take over the panel discussion, that would be great. And I request all the participants to actually pose their questions or unmute yourself to ask questions for Dr. Wang. Thank you.
So Navina, should I look at the chat for any questions, or how are we?
I think, Dr. Sharma, why don't you start with a question for Dr. Wang and then have the discussion on, and if there are questions coming in, I'll just alert you.
So Dr. Wang, fantastic talk, and I can't agree more with all the points you presented, especially with the importance of preconception counseling. So a lot of the patients who come in, a lot of the patients that I see several times are, come in with undiagnosed cardiac conditions that sort of get revealed in the second and third trimester. So what is your experience in dealing with those kind of patients who actually come in with no cardiac diagnosed conditions, And then they do have those kind of risk factors, like their advanced maternal age. There is obviously a higher rate of obesity, and then they come in with the symptoms that sometimes a lot of the obstetricians think that they are compatible with just normal pregnancy. So patient presenting with first onset of shortness of breath or coming with increasing pedal edema. So what do you recommend? How should we approach these patients? Should we go directly to the cardiac workup? Sending them. Should I be sending those patients? Should the normal obstetrician be sending those patients for a cardiac workup? Yeah, just your take on that.
I think that this is a very common phenomenon, especially as young women and healthy patients otherwise are very well compensated, even if they have cardiovascular disease. And then, like I said, pregnancy is the woman's first stress test. Their body goes through so much physiologic change where it really is the needle that, tips over the camel. And that's when their cardiac disease is first discovered. I think for women who are at high risk for cardiovascular disease, they should be early screened, regardless of whether or not you think their symptoms are cardiac in nature. And that's the approach that the California program has taken up, is mass screening, because there's so much at risk, right? There's not only the mother's health at risk, but the child's health at risk. And so, even simple evaluations such as an echocardiogram and EKG and basic lab work can help really differentiate between abnormal and normal physiology. And we should really pursue early screening for patients. So, a lot of patients, they've done studies where 50% of cardiac disease is missed because patients were dismissed as normal physiology of pregnancy, but they truly had a cardiac condition.
Absolutely, can't agree more. I mean, in the CMQCC data, they were pretty clear about it. So as you presented, I think over 60% of the patients were just dismissed. Their symptoms were dismissed. They could have been just because they presented with these kind of symptoms, and they were just not taken seriously. So that new onset cardiac symptom, significant shortness of breath, sudden change in weight of the patient, or I mean, obviously they're not going to present with those kind of signs, that they should not have elevated JVD. I mean, these kind of things, you got to take the patient seriously. And I think you mentioned a very important point about biomarkers. I think there is a lot of myth in the community, in the medicine community, about, BNP levels are going to rise in pregnancy. They are going to be elevated. So not a lot of people use it as a triage tool, which is a very important point, that utilizing your biomarkers. And the one point I would mention here is, a lot of times, when the patients are delivered, especially the patients who have preeclampsia, in those patients I have seen BNP levels go higher, but again, they shouldn't go higher than 100. So 100 is a great cutoff in terms of the BNP levels. Okay, I want to give audience chance to ask questions.
Just beside, I'll also add a point that
Yes.
there's a huge overlap in preeclampsia and peripartum cardiomyopathy. So like you mentioned, if BNP is over 100, I start to worry about, like, as a future window, whether or not these patients are going to start developing peripartum cardiomyopathy. So any BNP level, above the abnormal threshold makes me concerned, and makes me want to, again, get that echocardiogram within 3 months postpartum, because that's the most vulnerable period of developing peripartum cardiomyopathy.
Absolutely, and this is a great area of research as well. So not a lot of data on what BNP threshold, say in a preeclamptic, what should be the BNP threshold in them to act as a triage tool to then go to the next step of getting the echo. Should we be doing that in all patients above 50 BNP, or can we create sort of is there a cutoff that we can, and then there's not much data about that. Okay, let me see. I think there was a question in the I think this is a question from Sasha. Just curious, how do you classify patients with prior history of spontaneous coronary artery dissection when doing preconception counseling?
So as mentioned, I kind of, when I was talking about the WHO, classification, there was no mention about spontaneous coronary artery dissection, SCAD. So I kind of drew a little marker of where I personally would put SCAD as between 3 and 4. And I think it depends on how the certain situations of which the SCAD occurred. For example, was a distal LAD SCAD versus a proximal LAD. There's the different risks, and in terms of counseling a patient, it really is a shared decision making. We present them with the data saying, pregnancy is again a very stressful time for your body. The reoccurrence rate of SCAD is high during peripartum, but it's not prohibitive of risk. Trying to counseling about what they value in terms of pursuing that. Additionally, as our reproductive endocrinologies improve, thinking about surrogate pregnancies is an option for some patients, although I will also mention that surrogacy is extremely expensive and may be cost prohibitive for some patients. So telling a patient, well, kind of walking them through, this is the risk, how much of a risk are you willing to accept? So I don't tell patients with SCAD they can't have children. I just present them with, well, this is your risk of having SCAD again. And based on this, we have a discussion, well, what can we do to reduce your risk? Let's look at your medications and optimize their status should they want to pursue further future pregnancies.
A great point. And again, you mentioned the CHAP trial briefly in the end. I mean, that kind of change, it was a practice-changing trial for us. Right after CHAP, we are all, going towards more tighter blood pressure control in chronic hypertensive patients, with really taking the threshold 140/90 seriously. It's 140 systolic and or 90 diastolic. So all these patients are being home blood pressure monitored, and we are titrating them as we go through the prenatal care. Our group published a paper in, this month, actually, 2nd November, where we saw, the chronic hypertensive patients, their risk of developing cardiovascular outcomes, right? Like significant cardiovascular outcomes was significantly higher even 1 month postpartum. And that paper is just out in the Journal of Obstetrics and Gynecology this month. One of my fellows, I'll say, is currently her thesis project right now is to look at the blood pressure threshold of 130/80 in all hypertensive patients, and we're taking all comers there: gestational hypertension, preeclampsia, superimposed preeclampsia, chronic hypertensive patients, and really remote blood pressure monitoring. So they're all going home with the blood pressure cuff, and we are monitoring them remotely and targeting to 130/80 blood pressures, with again the first line medication being either labetalol, nifedipine, and of course they are postpartum. So if they are not breastfeeding, we are even starting them on ACEs and ARBs if we need to. And about 193 patients enrolled in that trial, and we'll see the results. So it's again lots of area of exciting collaborative research that can happen. Let me see if there are any more questions. Nothing as of now that I can see.
There are no questions. Dr. Wang, it was an excellent presentation. I hope that this collaboration will move forward with a commitment towards women's health and women's cardiac clinic, focusing on obstetrics. So with that, thank you, Dr. Sharma, for being our panelist today. And everyone, have a good evening.
Thank you for
Thank you so much for inviting me. It was great being here.
Good night, everyone.
Good night.